Welcome everyone to today's webinar. I am Morgan Havener with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Stat and clicking Send. We are looking forward to hearing your questions. We will also have an audience poll during today's webinar. When we reach the poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. This session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. Our presenters today are Jerry Bullock, Chief Pharmacy Officer of Trellis RX, and Tony Zappa, Chief Solutions Officer of Trellis RX. At this time, I'm pleased to turn the floor over to Jerry to begin today's presentation.
Thank you very much. Just a little introduction of myself, and then I'll turn it over to Tony to allow him to introduce himself as well. My name is Jerry Bullock. I currently serve as the Chief Pharmacy Officer for Trellis RX. I started my career as a clinical pharmacist at the Miami Heart Institute back in the early 90s. Then I moved to Atlanta to work at the Georgia Poison Center and spent a few years in the retail pharmacy space with Kroger. And in 2006, I moved to Nashville, where I held the position of the Director of Pharmacy for Metro Medical Supply and Metro Medical Pharmacy Group, which was a private specialty distributor who had a strong presence in the dialysis, nephrology, and oncology spaces. During my time at Metro Medical, I worked with a large oncology and rheumatology practices such as the West Clinic in Memphis, Tennessee, and Tennessee Oncology in Nashville to help build and manage their specialty pharmacy programs. Then in 2011, I joined Vanderbilt University Medical Center with the task to build and grow their specialty pharmacy. And with the help of outstanding executive support, hospital leadership, as well as pharmacy leadership, we built what I consider to be a gold standard in health system specialty pharmacy, which was a high-touch clinical model with an in-clinic embedded pharmacist and liaison, which I feel has had an impact on patient outcomes. And this is demonstrated in the number of posters, publications, and presentations they have submitted, as well as other institutions that have similar models throughout the country. And in 2018, I accepted my current position at Trellis RX, where we seek to help health systems build similar high-touch specialty models as well. And with that, I'll turn it over to Tony to allow him to introduce himself.
Great, thanks, Jerry. So I'm Tony Zappa, the Chief Solutions Officer for Trellis RX. I've been in and around pharmacy for about 34 years now, and have done basically everything there is to do except nuclear. So hospital, retail, mail order, specialty, home medical equipment, and other things. I've been in and around the specialty space for about 15 or 16 years total, including some stints in the late 90s. And then most of my career in this century has been around specialty. That includes 3 years of running the specialty pharmacy operations and home infusion for Fairview, and also was the head of a retail pharmacy chain of specialty retail pharmacies for BioScript. So glad to be with you today.
Well, thank you very much. And unfortunately, right at this second, Tony, I don't have access to those slides, and I certainly apologize for that. And I was wondering if you wouldn't mind just kicking us off with the first slide, and then once I pull the slides up, I'll be happy to join in. Is that okay with you?
Sure, absolutely. It's the fun about doing webinars. So if you go to the next slide, Morgan.
Yeah.
So here's the information we're going to cover today, which basically will talk a little bit about background of specialty, why we believe that health systems are really the model that should be used, and why health systems have advantages in the marketplace. We'll talk a lot about the factors that really support that view and what health systems can do to both implement and grow programs, what you need to consider, some of the ways you can mitigate the risks around those requirements, and really how to build a program up. And then we'll talk about a specific example from Trellis's experience in Portsmouth, Ohio, called Southern Ohio Medical Center, where Jerry's been working with them for several months now and has some really good information on their performance to date. So with that, let's go to the next slide. Okay, we thought it'd be helpful just to frame the audience a little bit. So based on your registrations, here's who's in the crowd today. About 36% of people are employed by a health system, and about 64% then are employed by other parts of the healthcare system in some fashion. And if you look at the status of the specialty pharmacy programs for those people that have one, it's about 44% have a program in development, about 24% have a mature program. There's about 22% of people who are still evaluating whether or not they should be in specialty and how to go about starting if they want to do that. And then there's a certain percentage, about 10% or so, who really don't know what the status of their program was, which is not unusual. From Charles's experience, this breaks down to about what we see in the marketplace, where there's still a large number of hospitals and health systems trying to figure out if they have an opportunity or not, and if they do, how to get there. And even those programs or those people that are developing a program, they maybe have started in one or two places, but have really not been able to grow the program beyond that for several reasons, some of which we'll touch on today. So that's who's in the audience today. And we're hoping that you have some great questions at the end related to where you might be in this process. And I think, Jerry, you're back with us. I'll let you take over.
Yeah, thank you very much. So really, overall, this presentation summary is really broken down in a few spots, but really, health systems, we feel, are best positioned to improve outcomes, whether it be adherence, medication adherence, patient outcomes, and efficacy of specialty therapy. We feel like that embedded model we talked about, really serves as an integral part of the care team and has an effect on outcomes. There are significant barriers to growth, however, and acceleration of a specialty pharmacy service line, and Tony will talk about those a little later. Things like staff costs and availability, suitability of the technology, as well as ongoing leadership support from the C-suite on down, and then provider acceptance. We have to earn the business as pharmacists. The availability of the big C word, right, capital, and then also these overcoming these hurdles such as drug network access restrictions or even payer access. Then also benchmarking and analytics. How can we understand the market? Are we being effective? Are we successful? Are we having impact on patient care? And then obviously, these aren't computers, right? They're people. We have to deal with personalities. The people that in the high touch model, they're human beings that are actually looking patients in the eyes. And how do we communicate a way to change manage it to make these happen? So in order to overcome these barriers, we'll focus on the 5 key factors, really, such as that opportunity, understanding that opportunity. And it may not be as simple as we think by just getting an e-prescription report. It's pretty complex. There's a lot of different ways of looking at it to really truly understand that opportunity. And then building enterprise-wide alignment. Is this a pharmacy or an enterprise initiative? And then also developing trust for those physicians. Also key is leveraging data and analytics that we do have, and then also the other healthcare workers that we sometimes don't refer to as healthcare workers, but they are manufacturers and payers. They're in the healthcare environment as well. So next slide. So we do feel like the integrated health system specialty pharmacies are proving to be most effective, and there's some nuggets or results from a few academic medical centers and health systems that we know have their own specialty pharmacy. And medication adherence, are these patients, whether it be through proportion of days covered or NPR, in health systems, typically adherence outside of health systems is about 50%, whereas in these health system integrated models, we see a PDC in chronic inflammatory disease of 96%, for instance, or NPR for hepatitis C of 95%. And then you get into therapy completion, where it's so important in some of these diseases like hepatitis C to complete a therapy. The community average, depending on their source, can average around 60%, whereas in these health systems, it's 99%. Cure rates, also very important. In HIV, in the community, you may see a 33% suppression of viral load, where in an AMC or a integrated delivery network specialty, it's around 80. So there's patient satisfaction as well. When it comes to financial barriers for patients to be able to obtain therapy, one of our partners, over $5 million was attained in copay savings across 14,000 prescriptions. And then the all-important patient journey, as we've discussed with manufacturers and payers, and even our physician partners, the Net Promoter Score, or the patient journey. Typically, a Net Promoter Score is you measure detractors versus promoters. And Tony will talk about that, but it ranges from 0 negative 100 to a positive 100, where 0 is in the middle. World class, Apple is 89% world class, is 70% and above. And in these health system SPs, we're seeing net promoter scores in the upper 90s, which is world class. It's outstanding. So we feel like this integrative health system SP have proven to be the most effective models. But next slide. There are significant barriers to entry and growth. So, and again, I alluded to a little bit of this in a previous slide, but with things like program governance, capital, technology infrastructure, administrative processes, pharmacy logistics, dispensing the medication, and is this a pharmacy-centric or an enterprise initiative, and also these hurdles, payer and LDD hurdles, as well as in-clinic patient support. And we found, again, when I was at Vandy, and much other institutions had the same experience, we had to build a department within a department. In health systems, we knew pharmacy, we knew inpatient pharmacy, we did pharmacists, but then shifting to this outpatient ambulatory side with specialty pharmacy required kind of a different mindset, whereas the inpatient, more is less, right? The more you spend, the less you get, whereas in the outpatient side, the more you spend, the more patients you're able to help, and the more revenue you're able to realize. Next slide. So this gets us to our first polling question, which I really hope we get some great responses here. Really, the polling question is, what do you see as the biggest inhibitor or growth for your specialty pharmacy initiative? Is it leadership engagement? Is it health plan and manufacturer network restrictions? Is it physician engagement? Or is it access to funding? And this can be expensive, or is it something else? And I encourage everyone to be able to chime in and cast their vote. So this is great. This is great. And before I turn it over to Tony, it looks like for the vast majority of you, the largest contributor or barrier to growth is health plan and manufacturer network restrictions. And I could see where that would be come into place, where folks that are getting their specialty pharmacy off the ground or in place and running, but that's the biggest restriction. And with that, I'll turn it over to Tony to comment on the poll questions and answers, as well as take this into the next section.
Yeah, from the polling question, from my perspective and based on what we see in the marketplace, the health plan and manufacturer network restrictions is not unusual at all. In fact, it's usually an opening question about, well, what can you do for me about limited distribution drugs or about payer relationships? I am intrigued, though, to see the leadership and physician engagement here, because we've experienced both of those, where we may have a very strong advocate in a pharmacy VP or pharmacy director, but it's difficult to get attention from the C-suite, which, as we'll talk about in just a minute, is really important from a strategic perspective. And also physician engagement, we've experienced this as well, because physicians and other providers have personal relationships with patients, and they don't want those disrupted by people that they don't necessarily know or haven't had experience with. So both of those are understandable, and we'll touch on those as well as we go along. So if we can move on to the next slide, please. And so the next one you'll see is an agenda. We're going to move to item number 2 here. So if you can go to the next slide, please. So Jerry covered these 5 high-level areas we're going to talk about in a little bit more detail. There we go. The first one is how to frame your opportunity. And in fact, you need to frame it and then reframe that on a pretty consistent basis, because the world does change. There's new products launched all the time. There's potentially new practices that are started by a health system where you need to rethink the specialty opportunity. And there could be other changes as far as capital projects or other things go. It's also really important that you need to think about specialty pharmacy not as a revenue generating program per se. It really should be a clinical program at the start. And if we do our work correctly as pharmacists in the clinic setting and build trust patients, then the revenue should follow in the fact that we capture prescriptions within the system. So the case for change is around especially medications. It's about dispensing more prescriptions or generating more revenue. That then feeds into this building enterprise-wide alignment. And we say a lot that specialty pharmacy cannot be considered as just a pharmacy program. If you do that, you're not going to be able to be successful as if you make it a system-wide initiative. And the reason it needs to be system-wide is because there's a lot of strategic areas besides pharmacy that these programs touch. If you think about your health system, if you work for a health system now, it's very likely you're taking value-based contracts from large payers in your market. And that usually is on an overall cost of care basis. So if you're not able to provide all care for all patients who are affected by that value-based contract, you may not be able to manage your risk appropriately. Likewise, from just an operational perspective, specialty pharmacy requires a lot of support from other departments in the system, especially if you think about accreditation. So there's going to have to be IT support and marketing and HR and finance and other folks. And unless you think about this as a system initiative, you may not be able to marshal all those resources when you need them. Once you get the strategy built and in place, then you need to build relationships with not just physicians, but really all providers, all the way down to medical assistants. Because again, those are the people that have the existing relationships with patients. They're also going to be the people that we're impacting by the fact we're going to be in their clinics, or we're going to be somewhat redesigning their workflow, in that we want liaisons and pharmacists and other people to be talking with those patients. So we need to be adaptable. We need to fit the specialty care model into whatever workflow exists rather than try to make the workflow fit the care model. We also need to make sure that, as Jerry mentioned, that we're sensitive to change management. Not everyone likes change, and we need to make sure that we're communicating and always in front of people, helping them understand the benefits both to the patient and to the system by doing this. Then once we get the program in place, we're going to be generating data. We need to be able to leverage that data and the analytics that come along with it to go out to the marketplace and prove that our program is better than what is commercially available elsewhere. We often think about, well, what data do you need to collect? One of the things we'll talk about in just a minute is you can look at the accreditation programs as a minimum standard, because they've done a pretty good job of laying out, well, here's what you should be collecting on a daily, weekly, quarterly, or annual basis, and what you should be reporting back as far as quality markers to show your program is performing. And then we'll talk about what we can build on top of that as well. And then those data and outcomes then allow us to go to manufacturers and health plans and work with them more closely. You see the word embrace here, and it really should be a two-way communication in that we want to bring manufacturers the ability to improve the clinical outcomes for their products. We also want to bring health plans a better experience for their members, which could make them more competitive in the marketplace, which is not a bad thing for them. And all of that then feeds back to reframing the opportunity as we get more experience, as we generate data, as we have outcomes, as we identify new disease states or new drug therapies we can impact. We go back and see, well, what does that do to the overall program? How can we make the program grow over time? Next slide, please. So let's talk about building the case for growth. And when TrellisRx goes into prospective clients, this is the way we think about this. So what is the current state, and how can we prove out what that current state really looks like? So what the opportunity is. So what specialties do I have within my health system where I either own the clinic, employ the physicians, or have them under contract, as well as what's existing in the community that I may be able to influence through an ACO or through some other type of network. So what is the real opportunity today? And from those specialties, from those providers, what are they generating in the way of prescriptions? So we look at prescriptions, absolute prescription volumes, as well as we look at diagnosis by patient to see if there may be actually gaps in the prescription data. If there's a specialty in my system that I don't have, is it an opportunity to go and create a practice around that condition? Then we look at the change management requirements. How many clinics will we want to go into? How will we be impacting their workflow? How will we be impacting their patient communications? We think about how we would ramp the program up or how we would stage implementation over a 18 to 24 month period. So we don't go in thinking that we're going to be able to bite off everything in the first 6 months. That's usually unrealistic. Instead, we look at, let's do the first 1 or 2 clinics. Let's really get them going, make them successful, then move into the next 1 or 2, and then move into the next 1 or 2 after that. Also, critically important is 340B, in that it generates obviously more margin for health systems that are 340B eligible. In the market today, commercial margins on brand specialty drugs tend to run about 3 to 4%. which is really hard to make money at with all the expense and investment that you need to make with specialty. If you have access to 340B discounts, obviously the margins are much better, and you can use those dollars to provide more care to those patients. So hire in more clinicians, hire more clinic-based staff, expand out your clinical programs, follow-ups, patient management services, things like that. And then try to get a sense for what your current clinical performance is if you have a way to measure that. And we'll touch on that in a couple of slides, more specifically about data and outcomes. Once you establish your current state, then we can take a look at, okay, what are we going to anticipate doing over the next, say, 12 to 18 months as a first line opportunity. But we also need to consider what the potential is for program growth over time. And you see here the specialty care model in primary care. There's a lot of drugs that are used in primary care that people don't typically consider as specialty products, or there may be patients who have non-specialty conditions that really need the same services as specialty pharmacy. And the ones that I always look at is people with CHF who are on Entresto, for example, or the type 2 diabetic who ends up on insulin. They have the same support needs, they have the same clinical needs, oftentimes the same financial needs as people on. So how can we apply that care model to primary care and expand the program out from there? Network access we'll come back and talk about in a few minutes, but obviously how can I work with more payers, access to more networks? The community physicians, as I mentioned, who is sitting outside my system and may be able to influence and be able to provide services to them. And then how can I improve my 340B structure and what might be happening negatively about that? For example, if I'm going to sell off for practice, or if I'm going to divest of a certain condition or certain treatment, what does that do to my overall picture? And then in the future, and the future here is think 3 to 5 to 10 years out, where is specialty pharmacy going to grow? So what opportunities do I have to continue to grow the program through new introductions, through new disease states, as I mentioned? Are there going to be provider changes, either, again, reduction? Am I going to bring it into specialty? Am I going to sell off a specialty to a competitor, for example? Are there specialty gaps that I have within my system? For example, I don't have neurology right now. So what does it mean to me to be able to grow a neurology program? Do I need to work with community-based physicians? Do I need to anticipate practice in the future? Pricing is a consideration here, which leads into the next bullet as well. So if biosimilars truly are launched into the market, or some of the oral therapies go generic, what does that do to both my revenue and my margin opportunity over time? And who are my competitors? And everybody's got competitors. So when you think about it, are there other health systems, are the health plans working with other specialty pharmacies in a preferred exclusive relationship that becomes a barrier? Do I have clinics within my own health system that have relationships with specialty pharmacies? I'm going to have to work, as Jerry said, to bring that business in-house and to really make those physicians satisfied with what I can do. So competition is always a factor. Next slide, please. So I talked about broad-scale alignment around the growth plan. This is a system strategy, not just as a pharmacy project, to really be successful. Part of it also is speed, because if we have the system engaged, if the C-suite knows what we're doing, if they endorse and support the program, it's more likely other people are going to get on board than if those C-suite folks don't. So who are my stakeholders? Who do I need to work with from not just, again, within pharmacy, but within finance, within medical services, in the executive suite, within HR and IT? How can I get my projects prioritized at a higher level to make this work? Who is on my board of directors? When I was at Fairview actually carved out their pharmacy services many years ago into a separate LLC company, and they formed a board of directors with 2 of their CFOs from around the system, as well as president of the pharmacy and CFO. And they really were able to think about this as a for-profit company, very entrepreneurial, and treat it like it was another specialty pharmacy company in the marketplace. In fact, not just specialty, but retail and mail and other things as well. So think about who you might want to have on your board to help you direct and ask the right questions about what your strategy is and help direct that strategy forward. What is your business scorecard? I think it's pretty easy to look at P&L statements to say, did we make budget or did we make forecast? But what else should you be looking at? Meaning, what clinical markers should you be doing? What satisfaction markers should you be doing based on Mps Scores or other that we can really prove that, yes, we're improving the program over time and we are competitive with others in the marketplace. How will you market and communicate success? So what do you have within your system to let your employees and providers know, here's what the program is, here's what it's doing, here's the benefits that it's having for patients, here's our clinical performance, all of those types of things. But also, how can you build a marketing and communication plan to take to the outside so that other people in your market understand, well, okay, here's what my health system is doing, here's the benefits it's had to the community. I think Jerry will touch on this with Southern Ohio, because there it's very much a community focus. It's not really about the health system, and they've been able to have a great communication process with their local market. Now, one thing that's not on this slide, when you think about the stakeholder analysis, you see there's a grid in the middle, which is one way to think about this. I think many of you on the call may have used the RACI concept in the past. So who within the model, who is accountable for program performance, program success, who needs to be consulted on the program, and then who just needs to be informed. So as you think about the people within your system, think about this in the RACI and the RACI view. So who's responsible, who's accountable, who you want to have giving you advice. So this is your board of director type comment again. And then who do you just need to be informed, which is broader than what you may think at the beginning to really make the program a success. Next slide, please. So the next slide is all about physician engagement. And again, I want to broaden this to really providers, because it's nurses, medical assistants, it's other people in the clinics that we're going to be working in. And we really need to understand a lot of things before we actually start to work in those clinics. So how do those clinics work today? What is their workflow? Where do patients go when they check in? What happens to them next? When do they see the physician? When do they see a nurse? What happens to them when their visit is done? So where can a pharmacist or where can a liaison slot in that workflow? As well as physically, where would we see patients? Would it be in an exam room? Would we have a separate office or a workstation? Would we need to have a chair in the waiting room in order to see people in a confidential space? So how would we work within that environment? And also, communication here is really key. So how do we stay in front of the providers in the clinic, again, to help them understand, here's what we're going to be doing. We're going to be doing prior authorizations. We're going to be taking responsibility for financial assistance. We're going to be doing refill reminder calls. We'll actually handle refill requests from outside pharmacies if necessary. We're going to be doing clinical follow-ups with patients. We'll do medication reconciliation. We'll do adverse event reviews to lay out in pretty deep detail, here's what the pharmacy staff is going to be doing. So it's very clear what our intent is. It's not to take over work that people enjoy doing. It's not to take over work that we think they're doing wrong. It's really, we're there to be a resource so that we can get patients started on drug. We can remove any barriers to continuing on drugs so that people can be adherent and persistent with their therapies. We can achieve good clinical outcomes. We can help build trust with patients that they know they've got a place to come back to if they have questions or if they have a problem, and really look to the long term to work with these folks as you would expect in a clinic setting. Next slide, please. Okay, when we think about data, as it says in the title here, data really does underpin the outcome, because it's really difficult to demonstrate that your program is performing if you don't have data that you can use to create information to show it. So the way we think about this, there's 4 basic blocks that you need to think about. One is just the basics for accreditation, which is a requirement in most cases to get into payer or pharma networks these days. Then you've got data for specific to payers, what they might be looking for. And then we think about quality improvements, both on the service and the performance or the clinical side. So from accreditation, and I would invite you, if you have not read them, is to go back and read the standards for URAC or ACHC, even read the CPPA, the standards, which tend to be a little bit more clinical than the other two. And what you'll find is that they overlap to a pretty high degree when it comes to operational performance. So how quickly do you answer your telephone, for example? What's your hold time? What's your fulfillment performance? So how quickly do you get prescriptions to people? What's your dispensing accuracy rate? What's your delivery success rates, things like that. On clinical performance, most of it is around, did you counsel? Did you have proper written communication materials? Were you responsive? Did you have 24-hour access to a pharmacist, things like that? And then those accreditation agencies as well require routine quality improvement projects, a quality committee, error reviews, publishing results, those types of things as well. So it's important to collect those data, again, as a baseline to establish what you're doing. But also don't forget that there are requirements within HR about employee files and employee training. There's marketing reviews of communication materials and website literature and other things. There's IT requirements around disaster recovery and the fact that you actually do the tests. So when you think about data, don't just think about transactional data. There's other things in there as well. The other thing about telephone performance is if you're like most health systems, you have a specialty pharmacy, but you don't have a call center, because either your work is done out of a pharmacy or you may have embedded staff in the clinics who are providing a lot of this telephonic support. So you need to think about how you would collect data without a call center or without that type of a phone system. It's certainly doable. You just need to think through it in advance. Then when you think about data for network access, and we'll talk about this coming up here as well, is what payers think about. So what are you doing to reduce the overall cost of care? So by having this clinical care model, are we keeping people away from the physician's office or out of the hospital? So even though we're spending more on drug therapy, are we reducing costs in other areas to lower the overall cost of care? Can we have disease-specific metrics? So within MS, for example, could we have walking distance as a measure, or all of the other validated tools, especially conditions we build into our care protocols and establish performance standards? Completion rates and adherence rates are pretty basic, but it's surprising how many people don't measure them well or don't measure them at all. Same with adverse event rates. And then payer and provider satisfaction, we'll talk about Mps scores 2 slides from now, and how we would use those. Again, the trick with these data points is where do you find benchmark data? Because within specialty pharmacy, there's not a lot of data published from competing specialty pharmacies. So as Jerry presented data from health system specialty pharmacies that have been willing to publish, we do need to have more cooperation within the industry so that we can establish that health system specialty pharmacies are better than other commercial pharmacies, or we have room to improve, as the case may be. Now, when we think about service and performance improvements, they really do build upon 1 and 2. So when you look at the data from accreditation, you have to have a process to manage and improve them, obviously. So do you have an active quality improvement process? Do you have a just culture where people will be willing to report errors or mistakes that they made so that you can improve the program over time? And that requires a pretty active governance process, again, at a system level. So are you including nurse managers? Are you including patient safety officers? Are you including other folks that may have a say or may want to know about what's happening at a governance level? And similarly with performance improvements, take the data that you're collecting for network access, build that into your QI process, and again, review that at your governance committee meetings so that it's transparent, people can ask questions. That usually leads to better quality projects over time. Next question, please. Or next slide, please, sorry. So here's just an example of something else you need to do if you haven't done this, is start to establish a baseline for yourselves. So if you can't find baseline data in the marketplace, start measuring what you're doing. And in the interest of time, I won't go through these in detail. You'll get these slides. But you can see on the left-hand side some of the impact that health system specialty pharmacies have had in the oncology space here in particular. You can see the other clinical impacts in the middle. The one on the right is interesting because this is in a non-specialty environment. This was actually an academic medical center who applied that specialty care model, high-touch patient care model, in the acute MI patient. So they had a lot of people coming back within 30 days of their myocardial infarction. And what they tried to do was apply more upfront proactive patient care, and they were able to reduce their readmissions from 32% down to 15%, just by having pharmacists and liaisons involved in the process, following up with people post-discharge. So the specialty care model really does work in primary care. You just need to have the focus and identify the opportunities within your system. Next slide, please. So we talked about Mps scores a little bit. Here's an example of what that means or how that works. So basically you have a survey tool, you have values from 1 to 10, and what you do is you subtract the 1 through 6s from the 9s and 10s, so that if you have more people who are unsatisfied, it's more apparent. You actually get a low positive or even a negative score. And you don't pay attention so much to the people that are called passives here, but the 7 or 8s who may like the program but are not, huge advocates of the services that got provided. So in doing this, it really allows you then to measure yourselves against others in other industries as well. So when Jerry mentioned the Apple score of 89%, you can say, well, my program is at the same stature of Apple, or it's at the same stature of, Comcast, which actually has a negative score. So it just allows you to have, again, a different benchmark that you can use when you look at how your program's performing. Besides specialty pharmacy, you can look at other service industries as well. Next slide, please. And then after talking a bit about manufacturers and health plans, really, they have slightly different objectives and sometimes very different objectives from what you may have as a health system, but it's important to consider. So from the health plan perspective, they want to know, are the drugs that are being used, the drugs that I'm paying for as a health plan, are they being used correctly? So is the therapy appropriate? Are the right drugs being used for the right patients? Have other therapies been tried and failed, which usually gets picked up through a prior authorization process, but not always? Will the members of my health plan have a similar or better outcome and experience that I may get from another specialty pharmacy? In other words, why should I work with your health system? I already have a relationship with a pharmacy I like. What value do you bring to me? And then the last question comes up a lot, in that health plans think by working with health systems that their costs will go up. And we're very careful to counsel people on, you need to help the health plans understand you're not asking for any more money for providing services. You're really willing to do this at parity with other pharmacies in the marketplace, that just because you're a health system doesn't mean you're going to ask for more. And in fact, depending on your purchasing power in a lot of different ways, you may be able to reduce their pricing by 1 or 2 or 3% to give them a financial incentive as well. With manufacturers, oftentimes their initial questions are, well, how does your results compare to the clinical trial? So are you seeing more of abandonment rates or first fill? If you can do that, then they're going to pay much more attention than if you can't demonstrate your rates or your rates are worse. Are the care processes being followed and their mandates being supported? Do you have the same type of data collection and care management processes as other pharmacies who do support those? And then lastly, are prescribing and utilization data available? So system, doesn't mean that you don't have to meet the same data requirements as other specialty pharmacies. So make sure you work with your IT vendors or your IT departments or your system vendors to be able to both collect and then extract those prescribing and utilization data to report back. So Jerry, I'll turn it over to you to talk about Southern Ohio.
Great. Thank you, Tony. So the next slide is really a case example of Southern Ohio Medical Center Specialty Pharmacy. And Southern Ohio is it's sort of, I want to say it's unique, but it's similar to a lot of smaller medical centers that play a vital role in community health, that are sort of pillars of the community, but albeit in a rural area. And what we've done is improved community health by just applying an academic care model to a rural hospital. Southern Ohio is located in Portsmouth, Ohio, and unfortunately it's a hotbed of hepatitis C and HIV infections due to the location where it is with IV drug abuse and such. It's a great community, but they are kind of plagued by that problem. But what we did is, of course, there was an analysis performed. We worked with them to understand that opportunity. And we were able to enroll the first patient within 4 weeks of the program. So with the help of the medical center, within 4 weeks of us, they enrolled the first patient. And within 6 months, Southern Ohio expanded its specialty pharmacy to service 5 clinics within that 6 months. Some of those hepatitis C, infectious disease, GI, neurology, oncology. And at that point, as Tony talked about the primary care, there was a cardiology group that heard about the specialty pharmacy, and they realized with Entresto and some of these PCSK9 inhibitors that required specialty pharmacy, the high-touch model as well. So they pleaded or petitioned the administration at the health system, hey, we want specialty pharmacy as well. So it's actually business that came asking for us. We did have to deal with the same challenges that everybody does, is overcome initial provider resistance. And like Tony talked about, we wanted to make it clear that we weren't there to replace or make their care, to change the care because they weren't taking care of their patients very well. It's really, we wanted to enhance the great care they were already providing. And that was one of the messages we had. And we also had to earn the business. We weren't the carnival barker waiting for business to come up, but we actually had to earn the business with that high touch model with the pharmacist embedded. The physicians, the nurses, and even the liaisons worked closely together, and they knew that we were taking great care of their patients, just like the physicians and nurses already did. We had to work their operations and flow because they already had a dispensing pharmacy, so we had to work with them to see how is this going to affect operations, and then also working through payer contracts with health systems, collaboration and leverage, and kind of taking advantage of that. The managed care team at the health system, who had leverage because they were the large player in the market, albeit a small hospital. We worked with them to be able to secure some meetings, to get some discussions going, and in process with URAC within the first 9 months. So the result, we served over 900 patients in 2018, and it's not a Johns Hopkins or a Fairview or a Vanderbilt, but 900 patients were affected, which was significant, having a positive impact on patient outcomes. A recent poster that we've just compiled with some outcome studies, we had 100% completion rate for the patients prescribed in hepatitis C therapy. And then most importantly, I think this is key, that hospital has a mission to the community to take care of its population, and we're addressing an unmet need in that population and improving community health. 8 out of 10 of those providers would recommend SOMC specialty pharmacy to friends or a family. And this also provided a new revenue stream for the health system that was previously uncaptured and actually leaking out to pharmacies across the country. The profitability of that health system specialty pharmacy was immediate. So that was very, very positive for the health system. And I think the large takeaway for this slide is you don't have to be a large academic medical center or a health system to have an impact. From a financial standpoint, realizing that have an impact in your localized patient care. So kudos to Southern Ohio for doing that. Next slide. So kind of to sum this up, I mean, we talked about knowing the importance of ongoing analysis, understanding why fostering trust with providers is important, speed to market, Tony addressed those well, and how to embrace collaboration with manufacturers, health plans to expand this. And really, I think now we're moving into our section where we're able to ask and address any questions from the audience. I appreciate your time so far.
So Morgan, you can jump ahead a couple slides if you want to the last one.
We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So the first question that we have here is from one audience member. They'd like to know, can you advise on how a health system that is considering a specialty care model into their system would gain access to LDD, and if there is a listing of such drugs?
Okay, 2 parts. So let me answer the second part first. So getting a list of LDDs can be a little bit challenging. I think depending on who you talk to, they might have a slightly different list. We're happy to talk to you about that to help you define what we think about limited distribution. I believe in Medispan or First Data Bank, they're starting to include flags where they identify them as well. But again, their values may differ from what other people think. So feel free to reach out to us and we can have a conversation kind of offline here. Getting access to those it really is think about it as a longer term process. It's not something that you're going to be able to do in many cases within a couple months. And the reason why is because many manufacturers already have established relationships with pharmacies or other distributors that have been in place for years. And they find those to be working fine. So really to break into those networks, you need to establish why it would be better for them or good for them to add your pharmacy or your health system, especially pharmacy program, into their network. Is it that you've got a large population of patients already in your health system where you're already providing care? Is it that you have proven outcomes that are better than others that they may be using as their limited distribution drug partners? Is there something unique to you that would benefit them and be able to actually demonstrate very clearly that your clinical performance and operational performance related to REMS and other programs is strong? That's been my experience, Jerry. I don't know if you have anything to add.
Yeah, I totally agree, Tony. I think manufacturers like the high-touch model. I feel like that resonates with them. The high-touch model, it reduces abandonment rate and increases adherence. But there is that baseline that, as any specialty pharmacy has to have this bar that you need to meet, the capabilities that Tony talked about, the accreditations and performance metrics. But then those things that separate you as a medical center, access to the EMR, the data, to be able to prove that you can kind of bend the curve a little bit on adherence and also abandonment of therapy. I think that's key. But it is a long-term process.
Thank you to the audience for that fantastic question, and Jerry, Tony, your answers were very informative. Another audience is wondering, what are your top 2 to 3 sources for benchmarking data, and or how do you identify pharma and payer expectations?
Okay, benchmarking sources that I mentioned can be a little bit difficult because there's not a lot of operational benchmarking done in the industry right now. You can find published clinical trials or other papers related to things like adherence rates or therapy completions within certain disease states, things like Hep C or HIV. But when it comes to operational performance, dispensing accuracy or telephone performance or even basic adherence rates, things like that, that's a little bit harder. So there's where you may want to reach out to colleagues in the marketplace and speak to them one-on-one about how their program is working. Most of the time, and this has been my personal experience, if I've got a question and I reach out to people that I know, they're usually willing to share, as long as you're not the competing hospital across town. There are also work groups within, for those of you that are Epic users, for example, Epic actually has a specialty pharmacy work group. ASHP is developing a specialty pharmacy section now, so I would invite you to join that. There's certainly NASP, the National Association of Specialty Pharmacies, which again has a lot of health system-based members in it, and you can reach out to them and get some data from them. But it's usually going to be more informal type of relationships than formal. And Morgan, could you repeat the second part of that question for me, please?
Absolutely. The second part of the question is, how do you identify pharma and payer expectations?
Yeah, the easy answer to that is ask them. Every company and every health plan has slightly different objectives and slightly different information that they want to know. So again, establish the relationships, get to know who your local and regional pharma reps are, even national in some cases. Get to know the pharmacy directors at your local health plans. And I would encourage you to start locally. Don't think about biting off the national players, first. Think about those local health plans, especially the smaller ones that may be more willing to speak to you than the large national players. And just ask them, what would it take for me to get my specialty pharmacy program into your network? And they will usually come back with a set of standards or requirements that they expect you to meet that you can then start a negotiation about, well, do I have to be accredited day one? Can I be in process? Which accreditation do I need to get? Do I need to get more than one? Is there some latitude for me? And again, think about this at a system level strategically. So don't hesitate to get your CEO or your chief medical officer, your VP of contracting, get them involved with their peers so that you can get a sense for not just at the pharmacy level, but at a health plan system level, what they might be looking for as well. And Jerry, I don't know if you have a different experience than me.
No, I think just some of it's just basic, being present in the market. And for me, it helped to go to meetings, whether they're various conferences, CBI conferences or SMBF, and then reaching out to colleagues that are already in the space that kind of have pharma's ear and payer's ear already. So just kind of soak it in by osmosis and learn that way. I found that to be more helpful than just about anything.
Those are some really great points and really excellent advice for the audience. Thank you, Jerry and Tony. The next question is a medication assistance program part of the services provided by special pharmacies?
Typically, yes, and that can take the form of a couple things. One is just helping people get access to the already available programs in the market. So there's the pharma-sponsored copay cards or copay assistance programs for those that are eligible. There's also the patient assistance programs or the free drug programs that, it's not many patients. It's only maybe 3 or 4% of patients typically, but it's a really necessary program that will help folks. There's also the foundation grants or foundation programs that you can get access to. However, we've seen with some of our clients and others in the space where the health system will actually create a charity care fund of sorts to help people with short-term financial needs in order for them to either get started or stay on their medication. Because the last thing you want is someone with a cancer diagnosis, for example, to start on a drug and then have to stop because they have an out-of-pocket issue, or they've got a deductible that gets reset at the beginning of the year, or something else gets in the way. So there's a lot of options to do that. We work with our clients to help them set those up if they want to do that, and look for alternatives, other creative alternatives as well.
Excellent. Thank you for the audience for asking that question and your participation. We have another audience member wondering, do you think that the national SPs are creating barriers with the payers to keep IDN SPs out of the channel?
Boy, that's a political question. I honestly don't think they are overtly. I think in some cases those large national specialty pharmacies they've been in the market a long time. They've built relationships with pharma companies and with payers. Obviously, there's some of those pharmacies have exclusive relationships with pharma or are part of smaller networks on limited distribution drugs. They've got a lot of experience and a lot of data to show their performance so that they get in front of payers and maybe have better access or better success than health systems that are new to the market. But I think there's, as Jerry said, the pharmaceutical companies that I've seen and health plans that I've worked with really do understand the high-touch care model, the clinic-based staffing model. They do understand the benefits of that. And I think as there's more and more experience in the market on a broader basis, I think they'll be more willing to look at that as an alternative to the large national players or even the large regional players. So it's, in some cases, it may just be a matter of timing. But I think as the data gets produced and get published, I think health systems will begin to build an advantage in the market. Jerry, I think you agree with me on that.
I do, yes.
That's a really interesting topic. Thank you for providing your insight there. Another audience member is wondering, are health systems in general looking to only service their own patients with their SPs? Or do you see health systems taking on community and national pharmacies for non-system affiliated patients?
Maybe, Jerry, I'll let you touch on that from your experience at Vanderbilt, and then I can talk about Fairview as well.
Yeah, certainly. Thank you. I think in general, most health systems continue to focus just on their own patients and employees. I think, and that's important when you're speaking with payers or even manufacturers, where you kind of start to cross into those PBM-owned specialty pharmacies or health plan-owned specialty pharmacies, kind of competing for that. So I think for the most part, again, health systems concentrate on their own. However, we have seen some systems try to create a for-profit arm or for-profit side where they want to provide that great care that they've done on the inside for their own patients and expand that to compete with the market and the greater population. Probably more regional. For instance, if you're located in the Southeast, if you're a large academic medical center, you may branch out and create a for-profit arm or an LLC and focus in the regional area. But yes, I see most of it's just local, their own patients. And Tony, feel free to chime in.
Yeah, what I've seen is really an evolution over time. So I may start with just servicing my patients, and then we often counsel folks on, hey, if you're going to build a specialty pharmacy program, think about your employee health plan as a springboard to get started, because you've got somewhat of a captive audience. And if you can start servicing your employees, which are usually part of a larger health plan, they're just a self-funded group, then you can say, well, let me approach them, that larger health plan, now that I have experience with my own employees and can show the benefits of my specialty pharmacy program, let me become a provider for that larger health plan. And then once you get some experience with that plan, then you can take it to the other plans in your market to say, well, look at how good I'm doing for health plan X. Why can't I be a provider for you? Or here's the benefits of being a provider for you as well. When I think about my experience at Fairview, that's exactly what they did. They started with their own patients. They took on their employees. They then went to the larger health plan that serviced their employee plan. And then they use that experience to go out into the market with Blue Cross and others to say, hey, look, here's how good we're doing with this plan. Don't you want to be competitive with them and introduce us into your network as well? And they've since built that in, as Jerry said, into a regional strategy, not just in Minnesota. So I think there are some ways to do that. Again, it takes a little bit of time. Think about this as maybe an 18 or 24 month strategy, but it certainly is doable.
Phenomenal. Thanks for answering those questions so eloquently. We have time for one more question, and it's actually a two-part question. So we have two more questions coming. So I'll just read the first one and then follow up with the second afterward. The first question is, given the largest specialty pharmacies are owned by health plans and PBMs, what incentives do they have to work with hospital-owned specialty pharmacies? How can health systems overcome these barriers to gain access? And is it just scale that matters? That's question one.
So really the question boils down to what's the incentive for a health plan to work with a health system-owned specialty pharmacies when they already work with, say, a PBM-owned or some other national player. It's really more about why health systems have leverage with health plans that they didn't have before. And I mean that in the most positive sense. So if you look what's happening in the market today with value-based contracts, with readmission penalties, with outright capitation in some markets, the health plans are taking on more and more of the financial risk related to patient care. And my message to the health plan would be, it's great, I'm happy to take on that risk, happy to be held accountable for the care that I provide, but at the same time, you can't expect me to have my most complex patients being served by a pharmacy that doesn't have access to my medical record, doesn't have access to the data in the medical record. I don't get any data on what they're doing. I don't see really any day-to-day operational performance measures on what they're doing. And I don't control the patient care that's being provided. So what we're seeing is health plans are being more successful with, health systems are being more successful with health plans that have existing relationships because of the fact that the tide is changing on who actually is at risk for that patient. And I think as that continues, then it doesn't matter whether the health plan owns the pharmacy. It's the health system being able to say, we're more than willing to work with you as a care provider, but we need to be able to provide all care.
Excellent. And the second part of the question is, are health system specialty pharmacies largely limited to dispensing those drugs that are covered under pharmacy benefits? Can one expand into drugs covered under medical benefits through white bagging?
Yeah, so most of the time when we think about specialty, we're thinking about prescription benefit level medications because they're typically take home. However, I think most everybody understands that the line between specialty and either clinic administered or infusion products is blurring all the time. So we've worked with systems, and I've seen other systems in the marketplace who are starting to branch into supporting infusion services and thus getting expert at billing on the medical side as well. So I think the day is going to come relatively soon. When you think about specialty pharmacy, they're going to be submitting claims both under medical and pharmacy. They're going to be dealing with prescriptions being given both to patients at home as well as in an infusion setting, whether that's hospital-based or community-based. And the level of services is just going to be a lot more integrated going forward.
Just great. This has been an awesome conversation between audience and both Jerry and Tony. And I want to let everyone know that TrellisRx will contact them after the webinar, as we didn't get to all the questions today, and answer any questions, and also that TrellisRx will be writing up a blog post post this webinar so that those questions can be seen. And Jerry and Tony, I just want to check in. Do either of you have any final thoughts to share?
No, I guess the one comment I would have for those health systems in the market, if you're going to do something with specialty, just start doing something, because it's necessary for your patients. Your patients want it. And it's, I think if you don't do something now, you might find within a couple of years, it's even more challenging then.
Perfect. And that is all the time we have for today. I want to thank Jerry Buller and Tony Zappa for this excellent presentation, and TrellisRx for sponsoring today's program. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks, Megan. Morgan.